Thank you to the organisers for inviting me. And it's no mean task, Jelena, so she's given me future strategies in kidney transplant. I have one disclosure to make. I am not an immune cell biologist, but I am coming at it from the clinical aspect, and I find the topic quite interesting. So I guess if we just look, first of all, at where we've been successful in the field of kidney transplantation. So we now know that we're very good at improving short-term allograft survival, and we've shown that basically from the beginning of kidney transplantation, where it was initially an experimental strategy, and now it's kind of part of routine care for end-stage renal disease patients. However, where we're less good is at maintaining long-term good graft function. And as you can see from Jisu's talk, we do struggle with chronic allograft nephropathy. So what's helped us with the short-term allograft survival has been the introduction of the calcineurin inhibitors and other immunosuppressive agents. And these do come with their side effects, which obviously include increased rates of malignancy, opportunistic infections, and then through drug-specific side effects, there's increased risk of cardiovascular metabolic diseases, for example, like diabetes with tacrolimus. So what contributes to chronic allograft nephropathy? Well, you can have ongoing true chronic rejection. That's as a result of antigen-specific rejection. And in the context of pediatric disease, we obviously have a big problem with recurrent disease, such as recurrent FSGS. So how best do we try and tackle this chronic immunological injury? Well, first of all, if we look at the pathogenesis, it's several-fold. It includes poor HLA matching and previous sensitization. We have ongoing episodes of recurrent acute rejection. Then there's a subacute and chronic alloimmune response that comes from either suboptimal immunosuppression or non-compliance of the patient, which, as we all know, is a phenomenon within our adolescent group in particular. And then you have the non-immunological factors, such as older donor, poor graft quality to start with, and the deceased donors in particular. We can have ongoing problems with donor hypertension or the chronic toxic effects of the drugs that we're actually giving. So this brings us to a need, really, to develop more specific tolerogenic immunosuppressive strategies. And in the early 90s, there were several really interesting stories coming out with the efficacy of bone marrow transplantation, supporting a role for donor hematopoietic stem cell transplants and improving tolerance in certain patients who had malignancies, hematological malignancies that got BMT and then got a kidney transplant from the same donor, and in the long term ended up with very little, if not any, immunosuppression. But obviously, with bone marrow transplantation, you can have some very toxic preconditioning regimens that are associated with significant morbidity. So we now need to develop better strategies at improving tolerance and limiting the need for these conventional anti-rejection medications, which can, in effect, contribute to the chronic allograft nephropathy. So the field has really been moving towards cell-based therapies, and in fact, the group here at Guy's have been leading on that over a number of years now. And several strategies have evolved, basically looking specifically at regulatory T cells or regulatory macrophage cell therapy, in addition to mesenchymal stromal cell therapy, with the ultimate objective with any of these cell therapies of achieving tolerance, reducing or eliminating immunosuppression, maintaining tissue repair, and managing acute rejection. And I'll just direct you to a very nice review here from Catherine Wood in Nature Reviews Immunology in 2012. So regulatory T cells are very important in determining long-term allograft outcome. And different populations of T cells with regulatory activity have a role in promoting transplant tolerance. And these include your CD4 positive regulatory T cells, your CD8 positive regulatory T cells, got natural killer cells, and then the gamma delta T cells. So the regulatory T cells themselves are identified by constitutive expression of a transcription factor known as FOXP3+, and CD25, and then the interleukin-2 alpha receptor. And we know that the Treg number are reduced in acute rejection in the periphery. And those who have spontaneous tolerance post-transplantation, which is pretty rare, there are increased numbers. Now, interestingly enough, within a healthy person, we have 22 distinct Treg subpopulations, and that's on the basis of an ever-increasing number of markers identified through mass cytometry. So there was a very nice paper over 10 years ago now in an animal model showing that the transfer of regulatory T cells can be very effective in controlling acute and chronic allograft rejection. And the ultimate aim in patients is to infuse autologous Tregs from patients with organ failure. You expand the population outside of the patient, and then you infuse around the time of transplantation with the aim of tipping the immune balance in favor of regulation versus rejection. And there have been several proof of concept studies and safety and tolerability trials which have now established this as an effective strategy. And one ongoing study, of which the team here at Guy's are participatory, includes the ONE study. And this is just, the NCT number there is just one of several which you can access through the Clinical Trials Government website. It's effectively a multi-center phase 1 and phase 2 study in living donor recipients to assess the safety and feasibility of administering Tregs derived from recipient mononuclear cells stimulated with kidney donor mononuclear cells in the presence of belatacept, which is a co-stimulatory blockade. Secondary outcome measures for this trial include the presence, potency, and specificity of Tregs in the peripheral circulation of kidney transplant recipients. And then the overall long-term goal is how can we actually reduce conventional maintenance immunosuppression within 60 weeks after transplantation. And that study is still recruiting. So where do your circulatory T cells come from? Well, they're actually very low volume under normal circumstances in your peripheral blood. So that's problem number one. And groups have been now looking to try and increase the number of Tregs, and they actually have a very good source in thymi. And in particular, in pediatric thymi, this seems to be quite an abundant source, with over 500 times the volume compared to your peripheral blood. And in addition to that, they're thought to be functionally superior, more stable, and they can suppress the proliferation of the CD4b and CD4-8b T cells by 70% in co-culture, show a lower class 1 HLA levels and fewer HLA-DR positive as compared to Tregs expanded from the peripheral blood. And this group that published this short story in Transplantation last year are now going to be trying this particular strategy in some heart transplant recipients. So a second challenge is, obviously I mentioned about the peripheral volume being quite low, is how you actually expand those peripheral Tregs. And you can do that through two different strategies, and groups are continually working on that. But the key thing is to try and maintain their effective function once you do transfuse them, and how best to do that. And again, I'll refer you guys, if you're interested, to an excellent review by the group here in Current Opinion in Organ Transplantation just out this month. So the field is now moving even towards designing T-induced regulatory T cells specific for donor alloantigens. And I think this is a very exciting field because you're allowed to hone in on specific MHC class 1 alloantigens. And again, the group here have developed a HLA-A2 specific CAR T cell, which will be very exciting going forward. And we know that the CAR T cells have been used with great tumor suppressor effects in the cancer field. So coming into solid organ transplantation, having a designer CAR T cell for your regulatory T cells would be a very personalized way of trying to ensure tolerance within individual patients. So there are also other strategies besides regulatory T cells. Some groups have been working on regulatory macrophages, as well as mesenchymal stromal cells, for example. And all of these subgroups can actually help with regulatory T cell induction, as well as suppressing your CD8 positive cytotoxic T cells to prevent rejection in the first place. And regulatory macrophages have been isolated from the organ donor, can be administered intravenously to recipients of kidney transplants of living donors, and have been shown to have no deleterious impact on graft function. You can withdraw tacrolimus within the first 24 weeks after transplantation. This is in certain contexts and in certain patients. And again, there's another clinical trial, which is a follow-up study using regulatory macrophages as part of the ONE study. And I'll just refer you to that clinical trial number if you wish to read more about that. And there's a paper that's just come out in June from Ramuzzi's group in Italy, where he's been working with mesenchymal stromal cell therapy. And these are bone marrow-derived MSCs, which can be either autologous or from the donor itself or from a third party. The administration can be either intravenous or, as I mentioned, you infuse direct into the donor organ before transplant, or you can co-transplant at the site of the allograft. The dosing regimens are being worked out, single, double, or multiple, and it has been shown in certain patients that you can have a lower incidence of acute rejection, a decreased risk of opportunistic infection, and certainly at 1 year, an improvement in estimated renal survival. And this is the paper just out where they've actually done a follow-up over 5 to 7 years of this phase 1 study, and have shown that in these, it's a low number of patients actually, only 4. However, all 4 patients had stable graft function during the 5 to 7 year follow-up without increased susceptibility to infections or neoplasm. So this is, I'll refer you again to 2 ongoing trials to look at the long-term effects of MSC therapy, and the trial numbers are at the bottom there. So moving on to the second problem that we have about recurrent disease in kidney transplantation. Well, what's new? I can just kind of go over what we've had published over the last 2 years. I still think we're a long way off from trying to understand the pathogenesis of this disease. And the objective of this part of the talk is really to, what is the latest on pathogenesis, discuss a Nature Medicine paper that came out last year, go over some of the preemptive strategies that have been published over the last 2 years in high-risk patients, and discuss some of the newer B-cell depleting agents. So SUPAR, which is a soluble plasminogen urokinase activator receptor, has been found to be very high in recurrent FSGS. It's thought to bind to and activate the beta-3 integrin protein, which anchors the podocyte foot process to the basement membrane, and therefore encourage podocyte migration, and therefore FSGS. SUPAR has been shown to be involved in the pathogenesis of CKD, and the big problem is where does it actually come from? So a very nice paper published by Jochen Reiser's group last year in January showed that actually the bone marrow-derived immature myeloid cells can be a source of SUPAR. And what they showed was that you had a marked increase of these immature myeloid cells in the bone marrow of proteinuric animals. And then when you transferred these pathogenic myeloid cells to wild-type mice, that was sufficient to generate proteinuria. They then went on to do a bone marrow transplant in these mice and substantially reduced the SUPAR levels, which then was very interesting in that it was able to rescue the mice from proteinuria. So what's the latest with regards to preemptive strategies? Well, the jury is still out on the role of preemptive strategies. And there was a large series published by a US group last year showing that actually preemptive strategy with prophylactic plasmapheresis, along with rituximab, did not in fact show a superior effect over the management post-transplantation. So what we really need in order to address the role of preemptive strategy is a randomized controlled trial, multi-center, across as many sites that can recruit as possible. However, there's been a lot of debate and talk about the role of low-density lipophoresis, and a lot of work has come from the Japanese groups. And I'll refer you to a paper published this year in the Journal of Transplantation, where, again, a small number of patients, all adults, were treated preemptively with LDL phoresis, along with rituximab, and had induction of CNI a few days before kidney transplant. But interestingly enough, in all 5 of those, none recurred. And then a really nice paper, very interesting paper, and we can discuss about the ethics, has come out in AJT this month, where we had a 5-year-old boy with primary FSGS received a deceased donor transplant. He had immediate and fulminant recurrence of his FSGS, which caused anuric graft failure, that was resistant to plasmapheresis and rituximab. So at day 27, a decision was made to retrieve the allograft from the first recipient and transplant it into a second recipient, age 52, who had vascular nephropathy. Immediately after retransplantation, the allograft regained function with excellent graft function at 3 years follow-up. That was a good story. And then patient 2, our high-risk 5-year-old recipient, who's now 100% risk for graft recurrence, goes back on hemo for 2 years, and he was then listed for retransplantation again. And this time round, he got pre-treatment with ofatumumab, which is against the CD20 protein, and it depletes the B cells. And interestingly enough, despite that strategy, he gets recurrent nephrotic range proteinuria post-transplant. He gets 15 sessions of plasmapheresis, and he gets a further 5 infusions of ofatumumab. And interestingly enough, on long-term follow-up, he is in remission with good graft function. So just to summarize, we've done a quick run through cell therapies and the promising avenues for induction of immune tolerance, gone through the challenges of Tregs, and the biggest challenge of all, of course, for us in pediatric transplantation is that of disease recurrence. So more work is needed there. Thank you very much.